Good morning from San Francisco. We have a 81-year-old female. She has a positive family history of colon cancer, mother and father, but refused to undergo screening colonoscopy until she was convinced to at least get a Cologuard, and it was positive, and then had a colonoscopy that showed this large polyp that is straddling the IC valve in the cecum. It's extending over the anterior and the posterior lips, and per the prior colonoscopy done outside, there was no extension into the terminal ileum, so it was intubated. So today we're going to remove this lesion, but it's going to be challenging because it extends over both sides of the IC valve. And it's extending over most of the hemicircumference of the IC valve. This is the gas view. This is a view that I normally don't get. I perform nearly all of my colonoscopies exclusively underwater or under saline. But I wanted to show you how this looks with gas so that you can compare it with the underwater view, which we are now going to get. I'm going to suck out the gas gently and then replace it with saline, and we'll go on near focus. This is an adult colonoscope, so it allows us to have the near focus capability, which we don't have, at least at this time, with the pediatric colonoscope. And we also have a larger working channel, which I like, so that I also have suction alongside the catheter, the snare, when I do the resection. So now underwater, you can see how the lesion starts to float up. It's almost as if we had injected it with submucosally. So it lifts up very nicely. You see it floating. Now, as you know, normally I don't inject at all because the water lifts the lesion up as if we had injected. But in this case, because it's extending over the posterior lip, I am going to inject on the cecal side to raise it up, because otherwise the snare tip may not fully engage the lesion. The goal is, of course, an en bloc resection. So I'm going to insert an injection catheter now, and I'm going to place it at the very edge of the proximal extent of the polyp. So the cecal part, the cecal end. There it is. And I'm going to lodge myself right here at that transition. And we'll advance the needle out. I'm going to have one of the assistants just hold the scope so it doesn't recoil as I go in. So I'm puncturing now and start to inject. And you see the lift. And just inject. So now the injection is outside of the polyp, so it's not going underneath the polyp. And stop. So I need to go a little bit closer in, because you can see I still have that valley between the proximal end of the polyp and the cecum. So maybe I'll try here, hold the scope please, and just pivot down like this, inject again. And I'm going to lift up like this, trying to see the injection. So what I'm trying to achieve here is to displace the proximal end of the polyp towards me by lifting it up. All right, stop the injection. All right, so you can see already that the proximal end is lifted very nicely. I've not injected through the polyp. So the back side is nicely lifted. So let's see if we can do a little bit more here. If you could hold the scope here for me, please. And now I'm able to get a little closer in to that transition point between the polyp and the normal cecal mucosa. So I'm just pulling back very slowly, looking for that transition point. And there it is. No, not quite. Sorry. So this is what I injected. You see the point there. You see it was still a bit of a distance away. There we go. Now hold this. So this is where I need to do another injection. Hold it there, please. And that's the actual transition point. I want to avoid the polyp itself. All right. Inject. There we go. Now we're getting a nice lift. All right, so we sort of worked our way from outside to inside and inject a little bit more. Stop. All right, and let's do one more if I can get it onto this side here. Now I'm using a viscous solution because I want it to have some durability. Inject again. There it goes. It's lifting nicely. Lifting, lifting. Okay, and stop, please. You'll note also that when you inject, you get some bleeding. That bleeding is something we don't like when we work underwater because it clouds the view a bit. In this case, it's still fairly good. Inject. Again. Lift this up just a little bit more. And the bleeding also stimulates peristalsis. So it obscures the view, and you get more peristalsis. So one more here. Inject again. Good. Stop. All right. So I've injected all around, and now we're going to take the 33 snare, and we're going to attempt an en-bloc resection. So I'm going to pull back now to the distal edge. So this would be the anterior lip of the IC valve. And what we injected was the posterior lip just beyond it to lift that backside up. And even with the injection, you can see that there's still some excavation. It's still going to be challenging to get our snare to engage the proximal edge of the polyp. All right, so let's make some diathermic markings to demonstrate that. Advance the snare out and pull it back. So it's recessed right at the tip. So using soft coag, could you please change the setting? Soft coag. Marking, yes. Good, good. So we'll just make a couple of dots here just so that I have some reference of where the edge is. And I want to just make sure that wherever I make my dot, it's normal. All right, let's go on this side. Just to give me sort of an approximate idea of where the margin is. And let's go over here now. And if you could hold, just to advance the catheter a little bit, I'm going to see if I can get to the proximal side here and maybe put some dots here as well. There we go. Okay. You can see the cloudiness from the bleeding, right? So now it's a bit more cloudy. Pull back a little bit. Going to go back a little bit and then now advance again. That's good. Pull back. Okay, let's get one more dot here. Advance, please. Okay, advance again, please. Underwater, you can see this so beautifully, the edge, where the actual edge is. Okay, so now let's open the snare, and I'm going to have you stay here. So I need one assistant to help with some of the torquing that I may need to maximize the amount of this polyp that I can get into the snare. So we wanted to float up into this snare, the lumen. So this polyp is maybe 4 centimeters. The snare is 33 millimeters. So we're going to have to contract the lumen sufficiently if we want to get an en bloc resection. So I've got the right edge, looks pretty good there. All right, the snare's on that edge. And now I just need to work on the left edge, and for this I like the jiggle maneuver. So I'm just jiggling the lesion to displace it into the snare, like that. So I keep jiggling and sort of rocking a little bit back and forth. And now we're going to do the torque and crimp. So the assistant is torquing counterclockwise a little bit for me. And then I can push in a little bit. That also helps displace the lesion. Okay, and this torque is what helps bring that center part out. That's where the actual, the valve itself is, where it goes into the terminal ileum. So you can see like there's almost a groove there. And I'm going to push in a little bit to see if I can displace this. And now I'm doing a gentle water pull. So I'm contracting the lumen just a little bit more. And you don't really see it, but it's coming a little bit closer. And every little bit helps here. Okay, and now you can see if I move back and forth a little bit, I'm sort of massaging it a bit more into the snare with the torque and crimp. And now start to close, please. It may have slipped, I don't know, but we'll see. So I'm going to push this away a little bit, and I'm just holding it closed, and I'm looking at the discoloration. Right now I'm doing the rotisserie, moving it around like this, and what I want to see is the right edge. There. Okay, that looks pretty good, because I think I scooped underneath, because it was floating up. And now we look on the left side, and what we don't know is the proximal end, right? The cecal end. But I think we're good. Now we're at the IC valve, which is very vascular. It bleeds very easily. Normally I use auto cut, but for the IC valve, I use dry cut. And I'm going to wait a little bit longer for the bubbles and the blanching, the two B's. So we're just going to sit here. This is saline, so it improves our conductivity. We have the heat sink effect of fluid, of the water, the saline. So I'm just going to step on the pedal, and my assistant is just holding the snare at this position closed, not cutting through until we see the two B's. Ready? Good. Here's starting. Okay, start to close slowly. Close, close, close. Now it's through. First thing I do is I just move this away like that, right? So you can see that the IC valve always has a lot of fat. Now, I may have to do some trimming, and I do. I can see I have some residual, but that's okay. I'll get that. So that's that proximal end. Open the snare, please. That unfortunately, I was not able to fully capture, but I'm going to do that now. So I'm placing the snare down here. Going to try to flush away. No. So I'm going to maneuver, if you could hold the scope here. And now you see all the fat there in the submucosa, and I'm turning like this, and I need to get it to go this way. Yes, very good. The assistant's helping. And I'm pushing in and start to close, please. Okay, so let's wait because I may not have everything on the left side. I'd like to get a better idea because ideally I'd like to have just two pieces now. Just hold it like this. I think it looks good. Now we want to give this, see, the fat tissue is very vascular. You see the vessels running through it, and it was already starting to bleed a little bit, so we're just going to wait a little bit longer, and usually it takes longer anyway to cut through fat. All right? Wait. Wait. Okay, now you can start to cut through. Okay, you're through? Good. All right, we push this away. CO2 and slowly coming back, and now you're going to see the final result. You can see it's half the circumference along the anterior and posterior lips. The margins look really good. Here you can see where I made a dot there. It's right on the dot. And then going this way, this goes to the terminal ileum. We were in there a few times. I biopsied the margins here very nicely. There's still a little bit of fat pad. There's the circular muscle layer. There's the edge going now towards the proximal end or the posterior lip. And we see the margins here, very clean. Looks great. There's the AO and the distance. And this is always challenging because of that steep slope that dips down into the cecal valley. And so now we'll apply some Curostat, our 3D matrix gel that is purported to see some drainage coming from the terminal ileum to also regenerate the tissue in addition to preventing rebleeding. And so we'll start from this end now, start to expel it out, please. There it comes. Okay, good. And I just hover over the surface like this and just let it drip on there. And sometimes you have to have contact because if you're not on the gravity side, then it'll go to the opposite side. So I'm just going to the edges is most important. So I'm just running along the edge like this. And then I'll dip down a little bit into the terminal ileum, even intubate a little bit. Okay, that looks good. We don't want it too thick because then it'll just wash off. And I think that's all we need. So we're done with the Curostat. And then we just retrieve our specimens with the Rothnet. We're going to pin it all down nicely onto some cork. And the largest specimen, which you'll see in a moment, was resected en bloc. Attempted en bloc, I should say. And then we did some trimming at the proximal margin. So pivot this over like this. Almost. Just have to get the right angle. There it comes. Turn clockwise, please. And I don't know if the basket is all the way open or not. Doesn't seem to be all the way open, but let's see. There we go. That's better. Okay. And start to close, please. There we go. Yeah, we got it. And then we'll take a look at it. Right? This nice big piece. That's our main piece. So I'm sorry I couldn't be with you live today, but hopefully you found this procedure, which no doubt is one of the more challenging. It's a defiant, what I call a defiant growth at the IC valve. The other defiant locations are the appendiceal orifice and the distal rectum at the anal verge. Those are more difficult locations, and you definitely need to commit more time and patience to resect those. Thank you.